This lecture is on Chapter 18, the General and Special Senses. A few definitions first. A sensory receptor is just a specialized cell or process that monitors conditions in the body or the external environment. It could be something as simple as a modified neuron or something as complex as the eye. A sensation is just sensory information arriving at the central nervous system. We may not and probably won't be aware of this. A perception is conscious awareness of a sensation, and perception is highly variable. For instance, a painful stimulus to one person may barely register, but it may be quite painful for someone else. And in fact, the same perception given our whatever is going on with us in our autonomic nervous system at the time may not even be felt or may be quite painful. General senses are sensations of temperature, pain, touch, pressure, vibration, and proprioception. The special senses are those of smell, taste, equilibrium, hearing, and vision. Receptor sensitivity is just what the receptor will respond to. All receptors do not respond to every type of stimulation. The receptive field is the area monitored by a single receptor, and the larger the receptive field is, the less precisely we're able to localize that sensation. Tonic receptors are always on. The eye is an example of that. Phasic receptors, they will respond, so they'll adapt rapidly and give a transient response, and then they'll go back into the rest state. Adaptation is the reduction in sensitivity in the presence of constant stimulation. That adaptation can be peripheral, which means adaptation at the sensor or sensory neural level, or it can be central adaptation, and that is adaptation that occurs at the central nervous system. An example of that is the sense of smell, where if we are exposed to something that smells bad, we become more tolerant of it as time goes by, and that is due to adaptation. This is an example of receptive field. So this neuron is monitoring this area, this one is monitoring this area. So if we're doing a two-point discrimination test where you're touching the skin surface with sharp objects, two sharp objects, if you were striking the patient here and here, the person would be able to discern that as two distinct points. But once you get both of those sharp areas into the same receptive field, then it can only be perceived as a single one, even though it's you're giving two pinpricks. And so if they were both in this area, you would only sense it as one. Now in the face and the hands, we have very fine two-point discrimination because the receptive areas are small. But when we get to the trunk, like in the back, the receptive fields are larger, and so we have less two-point discrimination. Okay, general senses. We can divide those into exteroceptors. They monitor the outside world. Interoceptors monitor the inside world. And proprioceptors monitor the position of joints. Nociceptors monitor tissue damage and pain. So, if you were punched in the nose, you would feel pain. So that may help you remember nociceptors. Thermoreceptors monitor temperature. So, thermo, like a thermometer, it's monitoring temperature. So we'll find those in the skin, muscle, liver, and the hypothalamus. Mechanoreceptors monitor contact and pressure, and we find those mostly in the skin. Chemoreceptors monitor chemical compositions of body fluids, such as our PO2, PCO2, and pH. Since the body only operates in a very narrow range for these, we have these chemoreceptors to make sure that they stay in that narrow range. Baroreceptors monitor pressure. So they're going to monitor pressure in tubular organs, such as the ureters and the bowel and blood vessels. So baro, a barometer measures atmospheric pressure. So baroreceptors, they monitor pressure in the tubular organs. So we'll find baroreceptors in the digestive tract. This monitors, is your stomach full? Is it not full? Are you hungry? Baroreceptors in the bladder wall let us know if our bladder's full, if we need to urinate. Baroreceptors in the carotid sinus will monitor blood pressure. Baroreceptors in the lung will provide information as to whether we need to take a deeper breath. And of course the baroreceptors in the colon will let us know if we need to defecate. Chemoreceptors in the medulla oblongata, in the carotid body, and the aortic body, they are going to monitor pH, PCO2, PO2, things such as that. So here is a carotid body tumor, and the carotid body lies right at the bifurcation of the common carotid artery into the internal and external carotid arteries. Here's what it looks like on an axial MRI. This would be the carotid body tumor, separating the external and internal carotid arteries. Referred pain is pain that is not felt in the location that the pain is occurring. And the mechanism of that is not a couple of classics: the liver and gallbladder. That pain in the liver and gallbladder are often felt in the right shoulder. Cardiac pain, particularly in men, is often felt as pain in the left side of the neck or in the left arm. Another classic is appendiceal pain. Appendiceal pain during appendicitis often starts around the umbilicus in the midline, and then as the disease progresses, the pain migrates into the right lower quadrant where we normally find the appendix. Ureteral pain is often felt radiating into the groin. I don't know why they've got this as referred pain, because stomach, this is exactly where the stomach lives. Small intestines lives in this area, and the colon we find throughout the abdomen as well, so I don't really consider that referred pain. Okay, so that is the general senses. So let's move on to the special senses now. Smell, taste, equilibrium, hearing, and vision. So olfaction is the sense of smell. The olfactory epithelium covers the inferior cribriform plate, the superior portion of the nasal septum, and the upper nasal concha. Remember back to the axial skeletal lecture, we learned those, the nasal concha, and what they do is cause turbulent flow with whatever we inhale, and that increases the contact with this olfactory epithelium. The olfactory epithelium contains these olfactory receptor cells, which are basically modified neurons. So here we see the olfactory nerve perforating through the cribriform plate. Here are these modified dendrites in the olfactory epithelium. So we smell something, it comes in here and comes in contact with the olfactory epithelium, which is sticky and traps the inhaled substances, and then these modified dendrites bring this information in the first order neuron. They synapse in the olfactory bulb right under the frontal lobes of the brain, and then is carried to the brain via the olfactory tract. And this is going to go right into the limbic system and other areas, and that it is not going to synapse in the thalamus. This is the only sensation that does not synapse in the thalamus before it reaches the brain. And so olfactory sensations are one step closer to the brain than any other sensation, and that's why olfaction, senses of smell, can elicit such strong emotional responses. Now, whenever in the lab, you see the olfactory bulb and the olfactory tract running on either side of the midline underneath the frontal lobes. If you label any of this just olfactory nerve, I'll be fine with that. Humans have about 10 million smell receptors. Dogs have about 1,000 times as many, so that's why they're better smellers than we are. Humans can identify about 10,000 different odors. I've already described this portion to you, and this as well. So this is a close-up of what the olfactory epithelium is. So this would be the cribriform plate with the olfactory nerves perforating through. These are the modified dendrites that are embedded in that olfactory epithelium that bring the sensations in. and we have these Bowman's glands here. As I said, this is a sticky substance in the olfactory epithelium, which helps trap these substances that are being inhaled. Okay, moving on to taste, gustation. Gustatory receptors are taste buds, and they're located on the surface of the tongue and adjacent areas of the pharynx and larynx, but as we get older, those areas become less important. And so it's basically these receptors on the tongue that are responsible for taste. The taste buds lie at the sides of the epithelial projections called papillae. So if you look at your tongue in the mirror, what you are seeing are the papillae, not the taste buds themselves. There are three types of papillae: the filiform, fungiform, and circumvallate. So the filiform papillae are on the anterior portion of the tongue. As we move back further, we'll get into the fungiform papillae. Fungus is, of course, fungi, and a mushroom is a fungus. And I think this kind of looks like one of those mushrooms. As we move farther back, these are the ones that are easy to see if you look in the mirror. These are the circumvallate papillae. Notice that there's a moat that surrounds these, essentially. And in that moat is where we will find the actual taste buds. So material that we've eaten gets trapped in this moat. It helps move in there by saliva, and then it gets exposed to these taste buds that can then send that information to the gustatory cortex, where that is interpreted as taste. We have 6 primary tastes: sweet, sour, salty, and bitter, and those were the 4 that were accepted for a long time, but more recently we've come to accept that there is umami, or savory, and that's found in protein-heavy foods, and it represents a sensitivity to glutamate. So that's why monosodium glutamate makes foods feel fuller. And then finally, water. It's hard to imagine that water has a taste, but it is generally acknowledged that water is one of the primary tastes. Number of taste buds decrease with age, and that's why older people tend to really have to salt their food to suit them, because the number of taste buds have just decreased. There's such a thing as learned taste aversion. So if you become sick within hours after eating something, you'll have an aversion to that food. For me, it was corn dogs. I got pretty sick as a kid, and the last thing that I'd eaten prior to that was a corn dog at the fair, and I have not had a corn dog since then. Wisdom of the body. So in a lot of cases, if we have a nutritional deficiency, such as say a sodium deficiency, we will crave the foods that include that deficient substance. Taste buds are monitored by cranial nerves 7, 9, and 10. Olfactory receptors play an important role in taste as well. I think everyone's familiar with that. If you've got a cold and your nose is all stopped up, food tends to taste bland. That's because we not only smell food through our nose, but we also get information, olfactory information from the food that we're chewing on. It makes its way up into the nasopharynx and is exposed to the olfactory epithelium. So in that case, we lose that whenever we're eating. We're more sensitive to things that taste bad than those that taste good, and that's a survival mechanism because most poisons taste bad. Let's look at the gustatory pathways. So here are the cranial nerves that are monitoring these taste buds. They're going to bring it in to the brainstem. The second order neuron will move to the thalamus, where it will synapse, and then the third order neuron will take it to the gustatory cortex, which is right near the sylvian fissure in the parietal lobe, in that primary sensory cortex. Okay, moving on to equilibrium and hearing. There are 3 regions of the ear: the external ear, which includes the pinna and the external auditory canal. Then the dividing portion is the tympanic membrane. Internal to the tympanic membrane will be in the middle ear, and that's where we'll find the auditory ossicles. And then there is the inner ear, and that's the part of the temporal bone that actually contains the sensory organs of hearing and equilibrium. So here's the external ear, which is the auricle or the pinna, and the external acoustic meatus. And we learned that when we learned the temporal bone anatomy. And we are in the petrous portion of the temporal bone here. So then we will encounter the tympanic membrane, which is the eardrum. Deep to that, we're going to be in the middle ear. So the middle ear runs from here to here. So we have the three auditory ossicles, the malleus, incus, and stapes, or the hammer, anvil, and the stirrup. I don't think either of these looks like a hammer or an anvil, but I do think this kind of looks like a stirrup. So the stapes attaches to the oval window. Vibrations of the tympanic membrane will vibrate the malleus, which will transmit to the incus and finally to the stapes. The stapes vibrations will be then passed through the oval window into the inner ear, which will set in motion the vibrations that will be interpreted as sound. Notice that the middle ear is connected to the nasopharynx by the eustachian tube. Auditory tube is also an accepted term. I've generally heard it referred to as the eustachian tube. Then finally we get into the inner ear, where we will find the organ of hearing, the cochlea, looks like a snail, and the semicircular canals that are the organ of equilibrium. And then finally we find the vestibulocochlear nerve. Now notice here's the facial nerve right next to it. Those two run together. They, in looking at MRIs, it's impossible to separate the facial nerve from the cochlear, from the vestibulocochlear nerve. So this shows us where we are in the temporal bone. So again, this is the petrous portion of the temporal bone. Here's the external acoustic meatus. Now, here is the jugular foramen, and here's the carotid canal. So the internal carotid artery is going to be entering the cranium at this point. Now here is the cochlea, the organ of hearing. Now notice how close the cochlea and the carotid canal are. And so that's why when you're in a really quiet room, you can hear your heartbeat. You're not actually hearing your heartbeat. What you are hearing is pulsatile blood in the internal carotid artery flowing right next to the cochlea, because sound is transmitted through bone as well as air. Okay, we've already covered this, the contents of the middle ear. Here we just see a more blown up view. I want to point out two muscles here. This is the tensor tympani muscle, and this is the stapedius muscle. These help dampen down our hearing. So because loud noises can damage our hearing, so the tensor tympani muscle will tighten here and limit the motion of the malleus, and the stapedius muscle will tighten and limit the motion of the stapes. So that's why, if you're driving in a car and you hear a great song on the radio and you turn it up, and then you're driving a little longer and you hear another great song, and so you turn it up even more, and you do this about 3 times, and then you get to your destination and you turn the car off. But none of this sounds too loud. But then whenever you get back in the car and you turn it on, the radio comes on and it's so loud you have to reach for the volume button really quickly because it's just so loud. That's because each time you turned it up, these muscles would tighten and limit the transmission of these vibrations to the oval window. But when you got back in the car, those hadn't been engaged, and so you saw how really loud you were playing the music. Okay, the tympanic membrane is about 22 times the size of the oval window, so that allows for sound amplification. The rest of this just talks about the what I just talked about with the muscles. And we've already mentioned the eustachian tube. So unfortunately, the eustachian tube, it allows equalization of pressure on either side of that tympanic membrane. But the nasopharynx is not a sterile environment, so we can often get ascending infections moving from the nasopharynx back to the middle ear. That causes an otitis media, or a middle ear infection. It can be viral or bacterial. It's typically viral, but if it's bacterial, you need to be on antibiotics. Mastoiditis is an infection of the mastoid air cells. Remember those mastoid processes right behind the ear? Those contain air cells, and so they can become infected just like any sinus can become infected. And this generally results from an infection from the middle ear spreading to the mastoid air cells. So if untreated, that can be very dangerous or even fatal, because once you're in the mastoid air cells, you're getting very close to the meninges, and which can cause meningitis, which can be fatal. That's pretty rare these days, because usually people placed on antibiotics well before that can be reach that stage. Okay, finally, the inner ear. So the inner ear contains the receptors that supply the senses of hearing and equilibrium. Okay, I want you to think of just, basically bony tunnels moving through that petrous portion of the temporal bone that correspond to the shapes of the cochlea and the semicircular canal. So that tunnel being burrowed out would represent the bony labyrinth. The bony labyrinth surrounds the membranous labyrinth. So this is a soft tissue type structure moving through the bony labyrinth. The membranous labyrinth is filled with endolymph. Surrounding the membranous labyrinth, interposed between the bony labyrinth and the membranous labyrinth, is fluid, and that is perilymph. Concept to get in there to understand, but just think, so the bone surrounding these structures would be the bony labyrinth. Now here's the membranous labyrinth of this semicircular canal. So it's going to be filled with endolymph. Surrounding that, between the membranous labyrinth and the bony labyrinth, would be, this area would be filled with perilymph, so fluid in both of those areas. Here's the cochlea, the organ of hearing, 2.5 turns, looks like a snail. These are the semicircular canals, so this would be the anterior or superior. I prefer superior. I think it describes it better, but either one is fine. And then we have the posterior semicircular canal and the lateral semicircular canal. Now, this is the vestibule. This sort of connects the semicircular canals with the cochlea. Inside the vestibule, we'll find the macula and the saccule. And these are organs that sense acceleration and gravity. Okay, and I think I've just covered everything already in here. So going back to that stapes, the last of the auditory ossicles, that vibrates the oval window, and that is picked up, that movement is picked up by the perilymph, which will then be evaluated and interpreted as sound. So sound waves, which are basically just waves in the air, disturbances in the air, they travel through the external acoustic meatus, and they vibrate the tympanic membrane. Tympanic membrane vibrations, we are sensitive and can interpret a sound, basically vibrations in the 20 to 20,000 hertz range. And as I mentioned earlier, sound waves are also conducted through bone. A conductive hearing loss implies an abnormality of the outer ear or the middle ear. Could be something as simple as just having your external acoustic meatus obstructed by cerumen, and then the solution to that is as simple as going in there with a cerumen spoon and scooping it out. But it can also result from scarring the tympanic membrane, the destruction of the auditory ossicles, often with recurrent otitis medias. We'll get destruction of the auditory ossicles. You can get fusion of those bones. A sensory neural hearing loss indicates an abnormality of the inner ear or a nerve problem. So you could have an abnormality of the cochlea causing a hearing loss, or you could have a tumor of the vestibulocochlear nerve causing a hearing loss. So again, this shows the structures here in the petrous portion of the temporal bone, and here is the cochlea and the semicircular canals and vestibule. So again, vibrations of the stapes will cause vibrations in the perilymph by moving the oval window. That will be transmitted through here, and these sensations then will be transmitted to the auditory cortex, where it will be interpreted as sound. All right, the semicircular canals. again, we have the anterior, sometimes referred to as the superior. That's the term I prefer, but either is fine. And the lateral and posterior semicircular canals. So these detect movement of that endolymph, and basically the orientation of these allows us to interpret movement in any direction or combination of directions. Bed spins are caused by alcohol being absorbed into the endolymph, altering its specific gravity, so the brain has a hard time interpreting the movement there. So this shows you, so here would be the superior or anterior semicircular canal. If you nod your head like saying yes, you're going to move the endolymph in this semicircular canal. The lateral semicircular canal, if you move your head side to side like saying no, you're going to move it in this semicircular canal. Moving your head from side to side, that will move it in the posterior semicircular canal. So that would be pure movements in either ways, but no matter which way you move your head, you're going to get movement in each of these semicircular canals, which the brain will be able to interpret as motion, and which way the motion. So this just shows the pathway, vestibulocochlear nerve here, synapsing in the midbrain, or sending off branches to the midbrain, and then moving up finally to the thalamus and to be interpreted in the auditory cortex, which now we're in the temporal lobe because this is the Sylvian fissure. So this is going to be temporal lobe. Okay, and finally vision. First, let's consider the accessory structures. The eyelids are the palpebrae. Remember that levator, palpebrae superioris, when we did the axial musculature. The medial and lateral canthus, those are just the corners of the eye. So we have a medial canthus and a lateral canthus. The palpebral fissure is just the opening between the eyelids. Conjunctiva, that is a simple squamous epithelium that's covering the inner surface of the eyelids and the outer surface of the eyes, including the cornea. So if you get conjunctivitis or pink eye, that is an inflammation or an infection of the conjunctiva. All right, the lacrimal apparatus, that's the collection of structures that produce and get rid of tears. The cornea is avascular, so it has to get all of its nutrients from the tears and has to get rid of all of its waste via the tears. The superior and inferior lacrimal puncta, those are the openings in the medial aspect of the eye that drain the tears into the nose. So here we see the external structures that we just talked about. This would be the superior palpebrum, the inferior palpebrum, the palpebral fissure. Here's the lacrimal gland, and this, we'll get a better look at this. This is the part of the nasal lacrimal duct, or this is the lacrimal sac. In fact, the nasal lacrimal duct runs through here and then empties into the nose. Okay, so here's the lacrimal gland, and these ducts are going to drain tears in over the eye. They will be emptied via passing into these. This is the superior punctum, the inferior punctum, going through the superior canaliculus, inferior canaliculus, into the lacrimal sac, through the nasal lacrimal duct, and into the nose. So when you cry and you get a runny nose, it's not because you have a runny nose, it's because the tears are passing in the normal way through and end up in the nose. For people who have excessive tearing, they really aren't producing excessive tears. They have an obstruction somewhere along this pathway of drainage. And so the tears can't drain in a normal fashion, so they just spill over the eyelid. And this is how we diagnose that. So a small catheter is put into one of those lacrimal puncta. Contrast is injected, and then we follow it through. And if all is normal, it should flow into the nose. And it is flowing into the nose here. But you can see that there is narrowing here in the lacrimal, nasal lacrimal duct. Okay, so let's look at the eye, consider the eye itself. So the outer portion is considered the fibrous tunic, and that consists of the corneum and the sclera. The sclera are the whites of the eye. So in cases of like liver failure, where bilirubin is getting into the blood, and people get jaundiced. You'll hear the term scleral icterus. That just means that where the sclera is turning yellow because of this. The sclera is a dense fibrous connective tissue. The cornea is that dome-shaped window over the anterior eye. It's avascular, as I mentioned earlier, so it has to get its nutrients and get rid of its waste via the tears. It's richly innervated, and it provides 2/3 of the focusing power for our eyes. And it's also the most commonly transplanted organ. The fact that it's avascular is a benefit here because it's not going to have as much access, or I guess I should say that the cells of our immune system are not going to have as much access to the cornea since it's avascular, so there's less chance of rejection. The iris is this pigmented musculature that gives us the color of our eyes. If you have brown eyes, it's because of brown pigment in the iris. The opening in the center of the iris is the pupil. The lens is this jelly-like substance that's kind of suspended behind the iris by these suspensory ligaments that are attached to ciliary muscles in the ciliary body. By contracting those muscles, we elongate the lens. By relaxing those muscles, we shorten it and make it fatter. And so by doing that, we can complete the final focusing power onto our retina. Cataracts are clouding of the lens, and most cataracts are just senile cataracts. They're associated with getting older, but you can get cataracts for other reasons. For instance, one of the a fairly rare side effect of tamoxifen therapy, that is an anti-estrogen therapy that we give to people with breast cancer. An uncommon side effect of that is can be cataracts. All right, so this shows the structures we've just talked about. This is the cornea, and this would be the sclera. Here's the pupil, which is the opening within the iris. Lens suspended behind the pupil by these suspensory ligaments, and which are attached to the ciliary muscles in this ciliary body. So again, you can see how tightening these muscles would result in thinning and elongation of the lens. So that's how we do our focusing. So let's consider those muscles. So this would be the sphincter muscle. A sphincter muscle is just a circular muscle. And these are radial. This is the radial muscles fibers. So they run like radially from around the pupil. So if the sphincter muscles constrict and the radial muscles relax, we're going to narrow the pupil. If the sphincter muscle relaxes and the radial muscles contract, we're going to get dilation of the pupil. So this shows the iris, and here would be the sphincter muscles running circular in here. And these are the radial muscles running in a radial fashion around the iris. Okay, so now we're moving back to the neural tunic, or the retina. Now the retina is composed of these neural and pigmented layers. Okay, the neural layers have the photoreceptors, the cells that will actually respond to light, and those are rods and cones. Rods are good in low light situations. They do not discriminate color, so that's what we'll be using for night vision. Cones provide greater visual acuity, and they are responsible for our color vision. We'll normally find rods around the periphery of the retina, and they're more common than cones, so they'll outnumber them by about 20 to 1. Cones are more centrally located, with the highest concentration in the fovea, which is our area of greatest visual acuity. Ganglion cells will carry this visual information generated by the rods and cones to the optic disc, and there it will leave the eye as the optic nerve. So and this is a good way to realize, if you know all the structures, not just follow a ray of light through the eye and see if you can name all the structures. Now, if you remember when we did the skull, the orbits don't point straight ahead. They kind of point angle out laterally. So to look straight ahead, we have to rotate our eyes medially, which is good because rotating the eyes medially to look straight ahead, we're going to get the visual information coming in and striking the fovea. Again, this is our area of greatest visual acuity. Notice that this is the optic disc, and here's the optic nerve. Now, this is a blind spot. We have no photoreceptors there, but we don't see the blind spot because our brain just fills in that information for us. And this shows the pigmented layer. The rods and cones have to be embedded in the pigmented layer. And so again, here's a cone, here's rods. Rods are purely grayscale. Cones will respond to color. They're going to be connected to the ganglion cells by these bipolar cells. So here we have the rods and cones embedded in the pigmented layer, bipolar cells, and the ganglion cells. Now the axons of the ganglion cells are going to move toward the optic disc, and then they will penetrate and leave as the optic nerve. But notice that visual information coming in has to pass through 2 layers of cells before they actually get to the cells that are sensitive to the light and will respond to the light. We divide the eye into chambers and cavities. Okay, first of all, let's consider the cavities. We have an anterior cavity and a posterior cavity. The anterior cavity is further divided into an anterior and posterior chamber. These chambers are filled with aqueous humor. Now, if you have trouble remembering, is the eye divided into anterior and posterior cavities or chambers? And what? Just remember, the first division, they go in alphabetical order. We divide it into anterior and posterior cavities. And the anterior cavity is subdivided into anterior and posterior chambers. The large posterior cavity is filled with this vitreous humor. It's kind of gelatinous. We don't get much of a turnover of this vitreous humor, so it rarely causes problems. However, we're constantly producing aqueous humor, and if it is not drained, then we get increased pressure in the eye, and that is the disease of glaucoma. That aqueous humor is removed via this canal of Schlemm. And the problem with glaucoma is if it keeps being produced but not drained, you're going to increase pressure in the eye. That pressure will be transmitted to the optic nerve, and you can damage the optic nerve, and glaucoma can result in blindness. Let me go back. So this would be the posterior cavity filled with the vitreous humor. Okay, let's consider vision a bit. We have binocular vision centrally. As we get more to the periphery, we have monocular vision, and that's because the nose blocks light. So if you're far out here, you're not going to be getting any information to your left eye because the visual information is going to be blocked by the nose. So only centrally do we get binocular vision. Now, notice that the vision, and we talked about this a bit with the cranial nerves, visual information that hits the medial portion of the retina is going to cross over. So let's just consider something out here in this visual field. It's going to hit the medial retina of this eye and the lateral retina of this eye. So the medial will cross over, lateral stays on the same side. So visual information on this side is going to be processed in the opposite side of the brain. And of course, the occipital lobe is where we'll find our visual cortex. Notice that we're sending off some information to our midbrain. Remember those 4 bumps back there on the midbrain? The quadrigeminal plate, superior and inferior colliculi. So we're going to get fiber sent off there. We're going to get some information sent off there on the way to the visual cortex. And this leads to the interesting thing of a blind sight. So let's say someone is blind, not due to damage to their eyes, but due to damage of the visual cortex back here. So in other words, their eyes are fine, they're sending information back here, but the visual cortex is damaged, so they can't see. Well, we're still getting information sent off to the midbrain. What this is for is basically, as if I see something out here in this visual field, the information sent off to the midbrain will cause me to orient to that, so that now I'm looking straight at it, and it is hitting the fovea of my eye, the area of greatest visual acuity. Now, frogs have this as well, but they have an extra connection. So if they see something out here in the lateral visual field, not only will they orient toward that visual stimulation, but there's another connection that sends information to their tongue to tell their tongue to snap out here, and hopefully they'll catch a fly. Fortunately, in us humans, we don't have that extra connection anymore. But this leads to the interesting phenomenon of blind sight. So let's consider, say someone's blind back here because of damage to their visual cortex. They still have these fibers. So someone got the idea, let's see if they can still see, but they're not aware of it. So, they take someone who's blind because of damage here, put something on the table, and say there's an object on the table, will you reach out and pick it up? And they're like, well, I'm blind, I can't do that. Well, humor me, give it a shot. And for the most part, they could reach out and pick it up, even though they had no visual awareness of this because of damage back here. But it was their midbrain that knew where it was. And some of these people can catch balls thrown to them because even though they're not visually aware of it, they still have visual information going to their midbrain. And that is the phenomenon of blind sight.